So bright. Good morning, everyone. So my topic for the presentation today is optimizing peripheral case management in the cardiac cath lab. And when I received this topic, I looked at it and I said, wow, that's a loaded topic. Because when we're talking about peripheral artery disease, we're talking about normally like more carotid peripheral in terms of renal and also below legs in the lower extremity. But the thing what I'm going to talk about today is more lower extremity. I have no disclosures. And some of the objectives that I'm going to plan on talking to you about is screening workup for peripheral arterial disease, medical non-invasive management of PAD, some case photos, and the questions afterwards. So why talk about peripheral arterial disease in the cath lab where we see coronary disease? Well, as you can see with this slide, basically the risk factors of PAD are similar to the risk factors for PAD, which is cigarette smoking, diabetes, hypertension, hyperlipidemia, and so forth. So cardiac patients that we see in the cardiac cath lab, we should suspect that they may have some sort of a peripheral arterial disease, either carotid disease, renal disease, or lower extremity disease. The way we kind of ascertain that information basically is a good history and physical, assessing risk factors, the skin integrity, exercise capacity, also comprehensive vascular examination, assessing bilateral arm blood pressures, auscultation of bruit in the carotids, examination of the legs and feet, and basically pulses. And when I say, examinations of legs and feet, unfortunately, we have to take the socks off to take a look at that and take a see what's going on. So, but also, we also rely on some non-invasive testing to let us know if there are any particular peripheral arterial disease. And most tests that we do are basically the ankle-brachial index, the ABI, segmental pressures, arterial duplex, which is done in the hospital, the CTA, and the MRA. So, this is just a slide showing ACC/HCA guidelines for management of PAD and who to perform resting ABIs on. And basically our patients are cardiac patients with risk factors who really doesn't complain of any leg pain, maybe atypical leg pain. Maybe they say they're able to walk 2 miles and then their legs hurt them. And classic claudication, which is pretty much pain in the legs or in the lower extremities with less than about a block to block ambulation. Chronic critical limb ischemia, which is kind of gangrene, kind of ulcer type foot, and acute limb ischemia is basically a cold leg kind of situation. So what is an ankle-brachial index? ABIs are just really taking blood pressures, the highest systolic blood pressures on both arms, and the highest systolic pressures in the DP and the PT areas. And basically, we do the math, and we get a certain number. And I'll show you the numbers and so forth. But the ABIs are established as a good PAD diagnosis. It is actually very specific for PAD and very sensitive. So it's a good test we could do really in the office, if you're working in the office, or even in the hospital. Exercise ABIs kind of helps us confirms PAD diagnosis and kind of elicit really exactly what the patient is complaining about. Sometimes when we go and interview a patient, we say, so you have pains in the legs. How far could you walk? And they say, like I said before, we could walk, I could walk 2 miles. And the reality of it is when you put them on a treadmill, they can only last maybe 3 minutes on a treadmill prior to getting pain in the legs. So it kind of helps us unmask some PAD symptoms on our patients. So basically, when we do the math, we get these certain numbers, and normal ABIs, resting ABIs are 1 to 1.29. Anything greater than that, we can say is non-compressible. You can see in the bottom part. And basically, we'll talk about sort of non-compressible arteries, which are calcific arteries. And so ABIs are really not too specific to that kind of situation. And again, limitations in compressible arteries, elderly patients, patients with diabetes, renal failure, that kind of thing. In addition to ABIs, we could also do segmental pressures, and which are a good measure of waveforms. And basically, these are not arterial pressures, but these are waveforms that will show us any significant occlusion or narrowing of the arteries within different areas of the legs. So for the way we do segmental pressures, basically we get blood pressure cuffs, we put them on the thigh, above the knee, below the knee, by the ankle, and by the feet, and we get these fancy waveforms. And basically, drop of blood pressure greater than 30 millimeters of mercury between the levels may indicate PAD, and a drop of greater than 20 millimeters of pressure between the limbs may indicate PAD. So the waveforms are interpreted and the pressure changes may indicate PAD, like I said. So segmental pressures look like waveforms. It's got a dichrotic notch. Looks like arterial pressures, it has a dichrotic notch. And normal waveforms has that nice look to it. As we go further down, it gets damped, and it shows you there's some sort of mild to moderate to severe ischemia in terms of occlusion. So ABIs and segmental pressures, widely available. Advantages are widely available, cheap, reproducible. Disadvantages is basically technician dependent. You got to have a good technician to give you good results. Time consuming, takes a pretty long time, and detection of collaterals are very low in ABI segmental pressures. So the next step really to ascertain if the patient has some sort of peripheral arterial disease is arterial duplex. And this is a good test that we do in the hospital. And basically, it could show us details of the vessel wall, if there's intraluminal obstructive lesions, and structures in the arterial bed. Duplex ultrasounds of the extremities is useful for diagnosis of anatomic location and degree of stenosis of peripheral arterial disease. This is again some sort of waveform that we see when we do the arterial duplex. Sensitivity of arterial sonor ultrasound is 92%, and specificity is 97%. And again, normal waveforms shows you is increasing ischemia as the waveforms dampen. MRA is again another good source of imaging that allows us to see really good images of the arterial bed. Again, just examples of how MRAs show. And CTA, again, another way of kind of confirming or helping us see what the arteries look like below in the lower extremities. Again, in order to get these type of great images, you should have, or the institution should have some sort of high-tech CT scanner with 64-slice CT, and it gives you we use a lot of dye for this, so you got to be concerned of patients with any renal problems. And again, with the limitations. If you have an uncorroborated patient, you won't have this kind of information. Again, renal and acute renal insufficiency is a problem too. So some take-home points. There's a few. Non-invasive vascular lab is the first line of evaluation in non-acute patients. ABI is easy screening tests. Beware of non-compressible vessels in renal and in diabetic patients. PVR and segmental limb pressures often combined with Doppler waveforms is a good analysis, is a good tool to analyze any peripheral arterial disease. Just hopping along, MRA is a good a good test to indicate for interventional planning, as is for CTA. Almost time up. Okay, so medical non-invasive management of PAD. So we do all these tests, and we get back results saying, oh, the ABIs show severe occlusion in the lower extremities. We get the CTA. It does gives us a good picture of the blockages. So what do we do after that? So basically, we kind of put them on some medical therapy, like in the cardiac. We put patients on maximal medical therapy. We try to do the same way with PAD. So again, lower extremity PAD is treated initially with cardiovascular disease, risk factor modification, hypertension, diabetic control, stop smoking, control the cholesterol, weight, diet, exercise. Pharmacotherapy of claudication is really silocitol and pentoxifylline, Trentol or Pletal. And I'm going to just really talk about silocitol, and the therapeutic supervised exercise program is very important. So silocitol gives you all these good effects, which helps us with PAD. Again, another slide that shows us that. Just a few graphs just to show that patients on silocitol, 100 milligrams PLBID, has increased their walking ability. Another slide showing the same thing. And of course, when you start walking, your quality of life gets a little better. You start shopping, you go out to the movies and so forth. So basically, your quality of life gets better. And talking about cardiac patients, we have patients in dual antiplatelet therapy, which is aspirin, maybe clopidogrel. And it shows, this slide shows that even if you put them on silocitol, risk of bleeding really does not increase. So it's a good drug for us CAD patients. And then the real contraindication really is any patient with any CHF. You cannot give silocitol to these patients. PAD exercise training program is a good prescription that we have patients on. We put patients on Pletal, and we put them on an exercise program which does increase the ability for patients to walk good distances. And basically what we do is we put them on a treadmill and have them walk. And initial workload of the treadmill is for symptoms, to see if they have symptoms after 3 or 5 minutes, and frequency and duration is noted. Important about the exercise program is that it should be a direct supervision. Patients should come to a lab or to an office, and we should supervise them as they exercise, because if you tell patients to go and exercise, they may not do it. And they'll tell you they did, but honestly they don't. Some case photos. I'm over 3 minutes. Just to show you gangrene of the foot. We open up the artery at 6 months, and foot is healed. Another case photo. Some debridement, and then after 6 months, foot is healed. And again, another one. And thank you very much for that. Yeah. So the questions are, which of the following are key risk factors for peripheral arterial disease? Cigarette smoking, diabetes, hypertension, hyperlipidemia, or all of the above? %. Which of the following are contraindication of silocitol? CHF, daily aspirin or Plavix use, or known hypersensitivity to any components of Pletal? There should be an E. E is ANC. So I just gave you the answer. You guys passed. Well, that's true. That's true too. You got it. That's right. All right. Thank you, guys.